In this capture, we're going to take a look at vision disorders. Let's start by briefly reviewing the eye anatomy, both on the external eye and the internal eye. Externally, you want to pay attention to the iris and the pupil. You want to be familiar with the conjunctiva, because remember, when you're putting in medications, eye drops, we're going to put them in the conjunctival sac. You want to be aware of the nasolacrimal duct, because you're definitely going to place punctal occlusion pressure there when you are administering a medication in the eye. Related to internal structures, you want to be familiar with the anterior chamber. You want to be familiar with the posterior chamber, your canal of Schlemm, and as well as your vitreous body and aqueous humor. A lot of this is going to relate to the outflow of this fluid as we talk about some different disorders. You also want to be familiar with the retina as well as the blood vessels in the eye. So beginning with assessment, examination of the external structures. You want to note any type of irritation or inflammatory process, any type of drainage. So is there redness, is there swelling? If there is drainage, what type is it? Is it clear and it seems like excessive tearing, or are we starting to see some purulent drainage? Maybe some thick yellow drainage, maybe some crusties that are kind of developing in there. You want to pay attention to the eyelids and the sclera. Okay, are the sclera nice and white the way they're supposed to be? Are they pink and red showing some irritation? Or might they be showing signs of jaundice that might indicate a liver problem? You want to note the pupils and the response using a darkened room. Is perla intact? Are pupils equal, round, reactive to light, and accommodation? You want to pay attention to the gaze and the position of the eyes. Are they symmetrical? Do they move in conjunction with each other? Assessing those extraocular movements or cardinal fields of gaze. As they're following your finger, are those eyes moving nice and smooth together, or are you seeing some jagging nystagmus? Okay, is there ptosis? Do you see any type of eye droop or eyelid droop? When evaluating vision, you always want to take an ocular history. Okay, have they had vision problems in the past? If they wear glasses, how long have they worn them? Do they also wear contacts? When looking at visual acuity, you can look at the Rosenbaum chart or the Jaeger chart. This is generally held about 14 inches from the eyes, and they need to be able to read that. And you're looking to see how far down they can read. The farther down the card, the smaller the print's going to be. You can also assess visual acuity with a finger count or a hand motion, and also looking at visual confrontation. This is important. Visual confrontation is a way to grossly evaluate peripheral vision. Okay, some of the disorders that we talk about, they might lose central vision, they might lose peripheral vision, so it's very important to get an idea of what their status is. Also looking at visual acuity, we look at color vision, the ability to differentiate with colors. We look at the classic Snellen chart to be able to look at the ability to see from a distance. The Snellen chart evaluates each eye separately, and then it evaluates the eyes together. So when we say a patient has 20/20 vision, what that means is the patient can read the 20 line at a distance of 20 feet. So if they're 20/40 vision, they can read the 40 line at a distance of 20 feet. So that's pretty important when you're evaluating visual acuity. Other diagnostic evaluation pieces, we can use the ophthalmoscope that provides direct and indirect visualization of the cornea, the lens, and the retina. We can use the fluorescein and the angiography dye. This we can use to detect a foreign body in the eye and examine blood flow to the retina if we think there's a problem with a clot or a blockage in there. The Amsler grid is used to identify problem areas within the fields of vision, where when we're looking at a grid which should show as straight lines, the patient may see it as wavy. That indicates, typically we see that a lot with macular degeneration. We can also do perimetry testing. Again, that's going to evaluate the field of vision. We're looking for scotomas, which are blind areas in the visual field. We can look at tonometry, which measures the intraocular pressure, or IOP, in each eye. Now, normal IOP is going to be anywhere from 10 to 21 millimeters of mercury. So that's pretty important. The slit lamp microscopy exam, that's going to magnify and be able to show us anterior eye structures. And the gonioscopy visualizes the angle of the anterior chamber. And that's going to be important when we talk about, fluid production and drainage from the eye. And that's a cyclical process, which is important because it keeps the balance of pressure in the eye. It doesn't let it get too high if it's working properly. Just a brief review of iMed administration. Obviously making sure you're cleaning the eye prior to installation. Maintaining sterility as you're instilling the medication. Instilling it into the conjunctival sac and applying pressure to the nasolacrimal duct for 30 to 60 seconds. That's to help prevent systemic absorption of the medication. We want that medication to stay and work in the eye. Couple things to keep in mind, that if your patient is on multiple eye medications, multiple eye drops, maybe there's an eye ointment, you need to understand what order those need to go in. And you also need to think about the timing between drops of the same medication. Usually we say at least 1 minute to 2 minutes between drops of the same medication in the same eye. If they are on multiple medications, typically we're looking at a time lapse of at least 5 to 10 minutes between each type of drop. Okay, so that is very important if you have patients who are on multiple eye medications. So looking at disorders, let's begin with impaired vision. And we'll start with refractive errors. And basically what happens with a refractive error, the light comes in and converges not on the retina. It's converging at a different part of the eye. So this is where glasses or contact lenses can help correct the refraction in order to get it so the patient can see appropriately. So you can kind of see how the light comes in and where it converges in a normal eye and somebody who has myopia and somebody who has a hypermetropic eye. So emmetropia is considered normal vision. Myopia, which is nearsighted, which means people can see near but have difficulty seeing far away. That's probably the most common type of impaired vision. There's hyperopia, where people have difficulty seeing up close but can see at a distance very easily. And then you have astigmatism, which is just a distortion that's caused by an irregularity of the cornea. And you can have somebody that has myopia or hyperopia who also has astigmatism. Okay, so it kind of makes things a little bit more complicated. So in talking about low vision and blindness, so low vision is considered visual impairment that requires devices and strategies in addition to corrective lenses. So someone like me, where I'm blind as a bat if you take my glasses away, but when you give me my glasses, I'm able to correct that, I'm able to see and do perfectly fine. So I am not considered to have low vision. But low vision, these people, even with the corrective lenses, they're still having difficulty seeing. They require additional devices and strategies. So these people would have a best corrected visual acuity of 20/70 to 2200. Blindness, true blindness, is 20/400 and no light perception. Okay, so when we talk about the definition of legal blindness, you have the best corrected visual acuity is not any better than 20/200 in their best eye. Or if we're talking about peripheral vision, their degree of vision is 20 degrees or less. So that's what would be considered legally blind. Not every patient you deal with is necessarily legally blind, but they may have low vision. Okay, you're much more likely to deal with that. The thing that you need to keep in mind is impaired vision is often accompanied by functional impairment. And that's really what we want to look at is how is this vision problem affecting my patient? How does it affect their daily functioning, their ADLs? So when you're assessing a patient with low vision, obviously you want to look at past medical history, past surgical history. What's the history of present illness? You want to look at their distance vision, near vision, their fields, the contrast, the glare, all of that stuff. But you have to include evaluation of their functional ability. Okay, how do they do with walking and navigating around their home? Okay, how do they do with carrying out their ADLs with not being able to see? How are they doing with coping and adapting to this change? Many times you'll see vision problems result in social isolation. So that's something you need to keep in mind, that we're looking beyond just the physical issue, but looking at the patient holistically. So how do we manage low vision? Obviously, as the vision is changing, they're going to go through a grief process. Especially if they have a love for reading and sightseeing and things like that, and all of a sudden they're losing that vision. That can be completely devastating. So we want to support their coping mechanisms, helping them learn to adapt to the environment, keeping things steady and keeping things stable. These are not the people that you go into their house and decide to rearrange their furniture. You want to keep things nice and stable. Placement of the items in the room. When you're describing their tray or describing where their objects are, using the clock method. Communication strategies. Eventually, if they go, fully blind, you look at options with Braille. You look at other methods for reading and communication. We now have audiobooks. What an awesome invention, for someone that is not able to be able to see enough to even read large print books anymore. Those audiobooks are a nice alternative, or other ways to communicate. Thinking about service animals, okay, we always think about the classic seeing eye dogs, things like that. But you also want to be familiar with the sight-guided technique, which is where you as the nurse, you're slightly in front of and to the side of the patient, and you're going to offer your elbow for the patient to hold on to. You don't hold on to the patient, they hold on to you and allow them to be guided. And make sure as you're doing this, you're describing the surrounding environment. We have approximately 10 feet until we get to the bathroom. I'll give you a cue when we get to the door. Looking at glaucoma. Okay, glaucoma is a disease related to intraocular pressure. So if you remember before, I said that normal intraocular pressure is 10 to 21 millimeters of mercury. And it all has to do with the production and drainage of the aqueous humor, aqueous fluid. Okay, so what happens here is it's not in balance. Usually the outflow is blocked, which builds up the pressure in the eye. And that increased pressure damages the optic nerve. And what happens is the patient progressively loses peripheral vision. Now, there are two types of glaucoma. We have primary open angle glaucoma, and this is the most common form. And this has to do with a problem in the canal of Schlemm and the trabecular meshwork, and it causes a gradual rise in IOP. And because that rise is gradual, the vision loss is very insidious. It happens very slowly over time, and because it happens so slowly, the patient adapts to it. They don't even necessarily realize it is happening, which is why unless they're going for periodic vision exams and unless they're getting their pressure tested, they may not even know that they have glaucoma. Now, the other type, the primary angle closure glaucoma, this happens very suddenly. It's a very acute onset, and the pressure spikes. And with this, the patient also tends to have a lot of discomfort. They see very rapid, acute onset loss of vision. So it's very clear that there's a problem, which tends to have people seek treatment much more quickly. So that's why we don't see this as much, and we tend to see it get reversed fairly quickly. It's the primary open angle glaucoma that is really what you're going to be dealing with your patients. So looking at glaucoma, before we get into the different types specifically with the manifestations, risk factors, certainly age. The older we get, the more likely you are to develop glaucoma. It has been associated with infection and tumors, diabetes. Okay, so this is another good reason for your diabetic patients for us to really educate them and really promote tight glucose control. Doesn't mean we can completely prevent glaucoma, but let's see if we can lower that risk. Hypertension, high blood pressure as well, is another big risk factor for glaucoma, as well as eye trauma. Okay. So as I mentioned before, the primary open angle glaucoma develops slowly, maybe some mild eye pain, but a lot of times there might not be any pain at all. They'll likely experience headaches and have difficulty focusing, and long term they're going to lose that peripheral vision. They kind of develop that tunnel vision. So typically their IOP is between 22 and 32. With your angle closure glaucoma, again, very rapid onset. It's going to be sudden, severe pain. A lot of times there's nausea and even projectile vomiting with that. They tend to see halos around the lights. Pupils may become non-reactive. This is very acute. We're going to treat them with IV mannitol and then correct the initial cause of the problem. So with diagnostic testing and findings, certainly the most common one that you're going to see with this is the tonometry, so we can assess the intraocular pressure. The ophthalmoscope will look at the optic nerve. We're going to look at assessing the peripheral vision and assessing the filtration angle of the anterior chamber. But the pictures that you see on the screen kind of depict the visual changes that are associated with glaucoma, where you can see the central part is still okay, but they've lost the peripheral vision. So with glaucoma, our main focus of treatment is keeping the IOP low enough to prevent progression of the damage. It's very important to understand that the damage is not reversed. They are not going to regain their peripheral vision, but we need to preserve what vision that they have left. And what we will typically do is use medications. And we'll talk more about these medications in class. This is part of your pre-class prep where you're looking at these different drug classes and how they work. But the beta adrenergic blockers, the alpha adrenergic blockers, the cholinergic agents, and the carbonic anhydrase inhibitors typically are consisting of your eye drops. These patients may be on multiple eye drops several times a day. There are also surgical treatments that involve that focus on improving the flow of aqueous humor. They want to open up a channel outside of the anterior chamber, and it's to help with the outflow of that fluid. Other things to consider, big focus is going to be the compliance with the prescribed regimen of eye drops. This is all about delaying disease progression and preserving their visual function. Okay, these eye drops are not comfortable. A lot of times they may cause a stinging or a burning when they're first put in. The patient will eventually adapt to it. It's not long lasting. It's usually with installation. But that can be a reason why patients may stop taking their eye drops. And they need to understand that compliance with the treatment regimen is important for maintaining their vision. Otherwise, we're not going to stop the progress of the disease. You want to provide both oral and written instruction on the meds. You want to include family in the teaching. And again, really help support them that psychological and social impact on their lifestyle. that both the loss of the vision and as well with the treatment regimen. Turning to cataracts, these are opacities that can occur in one or both eye lenses that are going to cause blurriness and visual changes. Very, very common. Outpatient cataract extraction and lens implant is one of the most common day surgeries, outpatient surgeries that you'll see, particularly in the older adult population. Big complaint that these patients will report is a glare during night driving. So you'll often see these people will start compensating and adapting in their life where they might not drive at night. Well, I drive during the day, but I don't drive at night. This is diagnosed with an ophthalmoscope exam, and the treatment for this involves an elective surgery. They're going to remove the cataract and the lens, and they're going to actually do an intraocular lens implant. It's actually a very quick procedure. Again, I mentioned it's one of the most common ones that you'll see. The procedure takes usually no more than an hour. The recovery time in PACU and the piece is about 30 minutes. It's a day surgery. Their healing and surgical recovery typically take about 6 to 8 weeks. Until they're really seeing the full extent, the final best vision that they'll have after the surgery. So clinical manifestations of cataracts, they'll have painless blurry vision, so you can kind of see the picture there that depicts cataracts. Again, sensitivity to glare, they'll have reduced visual acuity, particularly with night vision, and they might have some issues with color perception. They might see some double vision there as well. So again, surgical treatment is the key. Preoperative, it's your typical usual pre-op care for same-day surgery. They'll do some blood work. If they have a cardiac history or respiratory history, they'll have to be cleared by their primary care in order to be eligible for surgery. Pre-op, we will use drops to dilate their eyes, and they will use drops right before the procedure to essentially paralyze the eye muscle so it's not moving around during surgery. During the actual procedure, they remove the cataract and lens, and they will actually insert the new lens implant. So afterwards, post-operatively, they need to make sure they're wearing these special type of sunglasses that really helps protect that eye. Especially until the medications wear off, and they're going to be ultra sensitive to light. So they're going to wear these sunglasses. They want to avoid any type of activity that can increase intraocular pressure. So anything like bending over at the waist. We want to avoid sneezing, so it's not uncommon for them to be on like an antihistamine. We want to avoid any type of coughing or straining, hyperflexing their head and neck. Any type of restrictive clothing, tight shirt collars, anything around the neck we want to avoid. Basically anything that's going to significantly raise your blood pressure will also raise your intraocular pressure. Okay. Post-op, they may use some NSAID eye drops. They'll often use steroid eye drops and antibiotic eye drops. And they're going to be on a pretty frequent regimen of different eye drops, and that's going to be for several weeks. Big important things. This patient needs to call the provider immediately if their vision gets worse than it is when they first wake up, recover from the surgery. Okay, it may not be 100% when they wake up, but if it starts getting worse, if there's a change and it's getting worse, they need to call. If they start experiencing continuous flashing lights, they have signs of infection, they want to call. And very importantly, if they have pain that is unrelieved by acetaminophen, or if they have pain that's accompanied by nausea and vomiting, that is usually indicative of increasing intraocular pressure, and they need to be seen right away. Switching to corneal disorders, there's lots of different ones that are out there. Typically, when we talk about diseased tissue, your treatment, really, we're looking at corneal transplant. There's refractive surgeries, so you've probably heard of LASIK surgery to correct refractive errors. Those are all things that you can read a little bit about in your book. But basically, your post-operative care is going to be the same as if you're taking care of a post-op cataract surgery patient. If they've had surgery to correct the glaucoma, the outflow, your post-op eye surgery is going to be very similar. Retinal detachment involves the separation of the retina and the epithelium. It's painless. There's a sensation of a shade, a curtain, or a cobweb coming over your vision. There might be bright flashing lights, maybe a sudden onset of floaters. This needs to be addressed fairly quickly because we want to get things reattached. What they will do surgically, they'll do what we call a scleral buckle procedure, that they can essentially put this little wrap around here. It's a buckle that holds the sclera against the retina, and we're hoping that the eye tissue will heal itself. They can also do a pneumatic retinoplexy, which is where they inject a gas bubble or a liquid bubble or an oil bubble. And basically it has to do with the positioning of the eye, and they use that bubble, they got it floated in the right spot, and it pushes against the sensory retina, pushes it against the epithelium, and you want to keep them in that position so the body essentially will heal itself then. There's also the option of the vitrectomy, which is the removal of the actual vitreous body. So that's kind of a last resort right there. Usually you're looking at the pneumatic retinopexy or the scleral buckle. Again, post-operatively, regardless of what eye surgery you're talking about, typically it's done as an outpatient. So patient and family education is vital. They need to know the signs and symptoms of complication, especially related to increased intraocular pressure and infection. Okay. We want to promote comfort as much as possible for our retinal detachment patients. They may need to lie in the same position for a long period of time with their head stable. And that's all about keeping that bubble specifically in place to help push that retina back up to the epithelium. Okay? If they change head positions there, that bubble is going to move, and then it's not going to be doing what we need it to do. Age-related macular degeneration is also a common vision disorder. You'll see particularly in the older adult population. This is also a progressive loss of vision, but it's a loss of central vision. So risk factors: smoking, hypertension, diet low in carotene and vitamin E. Those are the things we know based on research. What these patients will see is they will lose depth perception. They will start seeing distortions in their vision, particularly in the central vision, and eventually they'll go completely blind. On the screen, you'll see the Amsler grid that we talked about at the very beginning. These people will see distorted lines instead of it being straight, a straight line grid, which is what it is in real life. This is how they see it. They will typically do the fluorescent angiography to identify areas specific as to where this is occurring. There are two types of macular degeneration. The dry, the non-exudative, is the most common, but basically it breaks down the layers of the retinal capillaries and it causes ischemia, necrosis, and this is where you see what they call appearance of drusen, which are areas where they're not able to see. So when you do visual acuity testing, they're going to have blind spots. If they're looking at words, they're going to be missing letters and that sort of thing. The wet macular degeneration, this is the proliferation of abnormal blood vessels, and it's the excess blood vessels and fluid in there that causes the distortion with the vision. AMD is typically treated with photodynamic therapy. So they'll use a special dye that's injected into the vessels, and then they'll use a laser treatment in the eye. That laser activates the dye, and it shuts down and seals the leaking blood vessels, and it does so without damaging the retina. The whole idea is to slow or stabilize their vision loss. What you need to understand is this dye is activated by UV light. So that dye has been in the patient's body. So they need to be taught to avoid exposure to sunlight or bright light for at least 5 days after treatment. Okay. Other treatments involve other injections that can inhibit blood vessel growth, but the photodynamic therapy is your main treatment for this. So teaching a patient with AMD and talking about nursing management, obviously dietary, we want to look for foods that are high in antioxidants, carotene, vitamin B12, and vitamin E in particular. These patients should be on daily supplementation in addition to good nutrition sources. Keep in mind their ADLs are going to be affected as the vision loss progresses. They may need to use optical devices, hand magnifiers, special lenses, closed circuit television, the audio books, that sort of thing. May need to use non-optical methods, patient positioning, so making sure they're closer to what they need to see. Contrast enhancement, maybe yellow background with black printing is a nice contrast. Increased and directed lighting, large prints, talking clocks and watches. There's a lot of different devices out there to kind of help with this. And then also think about ADLs in relation to transport. So community organizations to assist them with transportation to medical appointments and other things. And do remember to support both the patient and the family. Just a brief little ditty here on eye trauma. Obviously, an ounce of prevention is worth a pound of cure, so prevention is better. Patient and public education, making sure you're wearing appropriate goggles, wearing appropriate face protection, not doing, stupid things with fireworks and various things like that. Emergency treatment, if it's a chemical injury, a chemical splash, something got into the eye, you want to flush that eye with sterile water. I'm talking flushing for like a good 20 minutes. You want to keep flushing it, try to get that rinsed out. If there is a foreign object in the eye, you do not want to remove it. You actually want to protect it, put a paper cup over it, and tape the cup in place. And I would recommend patching the other eye too, because the reality is when you move your eyes, they move together. So you want to minimize the movement as much as possible. I had a person that I knew years ago as a child. Her and her brother were fighting over a pair of scissors, and she got impaled in the eye with the pair of scissors. And it actually resulted in her surgically having to remove her eye. So it's just really important to know how to respond to that. Once you get them to the emergency room for treatment, there's not much more you can do. Really, the initial piece is about trying to minimize the long-term injury. Eye infection and inflammation, just a brief thing. Obviously, it's going to be classified based on location. Your book goes into like hordeolums and all that. Infection is infection, inflammation is inflammation. Really, we're looking at a 3-pronged treatment. We want to treat the infection. If it's bacterial, we'll use antibiotic eye drops. If it's viral, we can use antiviral eye drops. We want to control their symptoms, so we can do that with warm compresses. We can use dark sunglasses to minimize the irritation of the light. We can use analgesics, artificial tears if it's drying and really irritated. And the third piece is really about preventing further infection or reinfection and transmission. So making sure they're washing their hands frequently, they're not touching their eye and touching other things. And then, of course, discarding of any opened makeup or contact lens products, because if they're infected and they use those again, they're just going to reinfect themselves. And finally, just to mention some ocular consequences of systemic disease, particularly diabetic retinopathy, and we will talk more about this in the diabetes unit. But diabetes is the leading cause of blindness in people ages 20 to 74 years. There's other conditions that can cause problems with the eyes. You think about HIV, You think about hypertension, but just be aware that some of those other diseases can have, visual manifestations.